Hello, everyone. I hope you're all ready for an exciting weekend, hopefully to relax, take a few moments off from work. Really excited to have you here today. We've got some amazing topics here with CT Lin, who's going to be talking about innovation. For those of you that are here live, you're going to have opportunity to have an engaging roundtable discussion. For those that are listening to the recorded version, welcome. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. Welcome. This is our 11th Innovation Beyond the Edge program, so we're really excited by this. Today's topic is Innovation Beyond the Edge, what's cool, what works, and what's crucial. CT Lin, the CMIO of UC Health, is our presenter today. And, I just wanted to take a moment to recognize that this series is really about creative problem solving and really about innovation by our members and by executives in healthcare. And so I want to also take a moment to thank Greenway Health, one of our overall series supporters. Kali is going to introduce CT here in a moment. Also, for those of you that are joining us, please stick around to the end. You're going to have a rare performance by CT. He's going to be doing a ukulele performance, so really excited about that. One of the reasons why we're doing this is that there are a lot of stories around innovation to share. A lot of creative problem solving, adoption of technology and solutions. And I can say that, innovation doesn't require bright, shiny objects. I'm a recovering patent attorney, and there are tremendous amounts of innovation that is not specific to tech, specific to inventions. So really excited for today. And I'll say that we also have 3 more of these scheduled next week and the following week. So with that, I'd like to just tell you that we've got 3 main sessions or 3 main aspects to this session. The presentation, which we'll hear from CT, then we'll have the breakout rooms, so about 15 minutes for our members to have an active, engaging conversation amongst themselves. And then we'll hear a Q&A followed by a performance by CT. So since I'm a recovering lawyer, I've got to read through a little bit of boilerplate here. We'll have everyone muted during the session. If you'd like to ask a question, please use the chat function to alert the team. Chat window will appear on your right side panel. To ask a question, type your message inside the panel, press the send key. Questions for CT can be posed in the chat function during the presentation, and we'll come back from the breakout rooms to address those. I'll ask questions in order they were received, and we'll try and get to as many questions as possible. If we don't reach all of them, we will have a follow-up and get those answered for you. Also, we're recording this session. It will be saved on the Chime site as well as the Chime YouTube channel. So you can feel free to go back and watch and refer to it. The virtual roundtables will not be recorded. So please feel free to have a candid, active discussion there. Also, if you have difficulty listening, you can certainly call in. If you do that, please let the host know to merge both of your phone and computer connection. If that isn't done, your phone will go into one virtual breakout room and your computer connection will go into another. Lastly, by attending the full session, the presentation and the roundtable discussions, you're going to earn 1 continuing education unit for CHCIO, CFCHE, and CHISL certifications. We'll review the list following the session and distribute the CEUs accordingly. So with that said, I'm going to hand it over to Kali Dirgampudi, the CTO for Greenway Health, to introduce our speaker. Kali is a tremendous supporter of Chime. He's been on our international board, has been just a phenomenal friend to Chime, and Greenway has been a phenomenal supporter and is an overall series supporter for Innovation Beyond the Edge. So Kali, please take it away.
Thanks, Jonathan. Really great to be part of this part of the series, and I appreciate the opportunity to introduce our speakers for Innovation Beyond the Age today. As Jonathan said, I'm Chief Technology and Innovation Officer at Greenway Health. Greenway is proud to be part of the ecosystem in helping our providers with everything from telemedicine to billing at this unprecedented time. However, I'm more prouder that we're bringing this in conjunction with our partnership with Chime. CT Lin, MD, CMIO at UC Health, 11 hospital, 600 clinic system in Rocky Mountains region, which was awarded HIMSS Stage 7 in 2016 and HHN's Most Wired in 2017. CT is Professor of Medicine at University of Colorado School of Medicine and board certified in internal medicine and clinical informatics. He sees internal medicine patients and also facilitates workshops on patient-physician communication, which is very near and dear to everybody. His national publications and talks include addressing physician burnout with EHR sprints and online patient communication with open test results and open notes. And his national awards include Health IT Innovator and Electronic Physician of the Year. CT also leads a team of 35 physician informaticists. Their vision is we improve physician and team resilience and effectiveness by building extraordinary relationships and innovative tools. So I'm not the only one. Looking forward to hearing more about what's cool, what works, what's important. And so it's my honor and privilege to pass it on to CT. CT, I'll pass it over to you now.
Thanks very much. I appreciate it. That's very nice of you. And I'm looking forward to giving my presentation, and I'll go ahead and share my screen. So what's cool, what works, and what's important. Some of you may know that the Chinese word for crisis is actually two characters. One character meaning danger, and the other character meaning opportunity. It's famously cited by our president, John Kennedy, a number of years ago. Opportunity is perhaps best translated actually as inflection point, and I think that actually represents our time right now very well. So what's the TLDR? Too long, didn't read? Sorry, not going to tell you to the end, and it's probably not what you expect. So what's cool? We are partnering with a company called Masimo for post-discharge wearables. We actually have a number of patients now going home from hospital with COVID-19 who were very worried about the biphasic nature of their illness, right? We know that patients deteriorate, get better, and then may deteriorate a second time. And that's prompted many of our hospitalists to keep patients in hospital longer than you would normally because you're worried, well, what's going to happen next? By having patients wear this on their wrist and the little bandage around their finger, we can watch pulse oximetry, heart rate, and respiratory rate continuously transmitted to their cell phone, and their cell phone updates that over cellular to our monitoring service. Our virtual health nurse actually can monitor up to 40 simultaneous patients with this device after discharge. We've had about 50 patients go through so far. We monitor them for an average of 8 days after hospitalization. We've been able to rescue 2 patients whose oxygenation got worse during that period of time, and no patients have had to be readmitted to hospital. So we think this has been a very cool pilot study, and we're looking to dramatically expand this going forward. Another cool thing, we're running a pilot or a big project with Sotera Visi for same thing, a wearable in hospital. Patients are wearing an armband that does a blood pressure, as well as pulse oximetry, heart rate, respiratory rate, and 2-lead EKG, as well as body position and body activity. And using this, we can detect patterns in patient behavior and look for deterioration alongside our EHR having deterioration risk scores. And this is all presented to not the bedside nurse, because the bedside nurse, God love them, they're running for their lives, taking care of these patients. We actually have a dedicated nurse. You see the back of her head here. watching 6 widescreen monitors. And this is an old photo because they're up to watching 8 widescreen monitors at a time. And we can monitor literally hundreds of patients throughout our hospitals for possible deterioration. And this has been so successful that we've been able to, we believe in the past year, reduce unexpected deaths by about 77 lives over the year prior with this monitoring system. We're also partnering with Agile MD, a pathways company. We are integrating this tool with live pathways into our electronic health record. So in the course of taking care of patients in our EHR, clinicians can link out to our COVID pathways. We've developed 6 interrelated COVID pathways. As everyone knows, during the pandemic, everything evolves every day and sometimes every minute. So as our command center makes changes on who's allowed to be tested for COVID-19 and which test to use. And now we have antibody tests and who's a candidate and who's not, and what's a candidacy for plasma donation, and that changes every day. We're able to put that directly into the pathway. So it's no longer a call to the command center. Hey, what are we doing with such and such? You look up the pathway, we know that this is kept up minute to minute. And we've been able to actually adjust this on the fly over the past 2 months. As a result, across our hospitals, we actually had one region of hospitals not performing well for mortality in critically ill patients. And after the launch of the pathway, within a couple of weeks, we saw the performance of that hospital improve to basically within range of all the other hospitals. So we believe that this has made a significant difference in the performance of our clinicians. We're also partnering with RX Review for prescription cost transparency. This is something that all of us as clinicians are frustrated with. Right? At the time of prescribing in the EHR, you write for a prescription, in this case, erythromycin, which is a very old drug. You might imagine is dirt cheap, but you would be wrong, because in this case, this is my prescription. I sent this to the pharmacy, and the patient called up irate that why would I prescribe a drug with a $146 copay? Just, it's completely insane. Right, and that's not something I would have expected. And now, with our partnership with RX Review and this information coming directly into our EHR, at the time of pending a prescription, even before I sign it, I can see, oh, $146, that's ridiculous. And look, payer suggested alternatives, $5 for Augmentin, $5 for Zithromax. And in my case, my clinical judgment, the $5 alternative is entirely reasonable. And off I go, I switched it. There's no more 20 minutes of back and forth phone calls between me and the pharmacy and my nurse. It's a lose-lose to do it the old way. It's a win-win to do it this way. And furthermore, right, you might imagine you get to the pharmacy, the patient says, I'm not picking this up. And if the patient or the pharmacy doesn't actually call me back, this ends up being non-adherence to therapy. Right, the patient doesn't actually get the drug. So worse than the patient, this costing the patient a lot of money, is the patient actually doesn't pick it up. And we know that across the country, about 1/3 of all prescriptions are never picked up, which is a tremendous waste for everyone, right? So, and then beyond what's cool, there's innovation that just works. And I want to highlight Doximity as an app. This is not a business relationship that we had, but we know that many of our physicians and many physicians across the country have signed up for this free service from Doximity, which is a smartphone app, which was originally designed as sort of a gathering place, a Facebook-like place for clinicians, but they stood up a phone call dialing app a number of years ago, and I've benefited from using it. And more recently, about a month ago, they stood up a video service. Now, we already have an integrated video service. Our EHR, in our instance, we've partnered with Vidyo, V-I-D-Y-O, as the integrated video tool that's inside our EHR, and we can communicate telehealth that way. And I'll talk about that in just a second. But when that fails, because it will, about 5 to 10% of the time, you'll either lose the audio channel or something goes wrong with video. Or moreover, my 90-year-old who because of CMS rule changes, newly became a candidate for a video visit, says, well, I have the smartphone, but I have no idea what an app store is. And can you imagine spending an hour trying to explain what an app store is and saying, if you would just download this app, I can talk with video. And Doximity bypasses that because with no install on the patient side, you can say, hold on, can you read a text? Ding, oh, I see a text from you. Oh, it says Dr. Lynn's inviting me to a visit. Ding. Oh, there you are. Just no install, very low lift, and I was able to communicate with my 90-year-old. in this way. And so there's stuff that just works, and this is just a highlight of that. We also are a Microsoft partner. We have the entire Microsoft suite, and as part of the Teams video function within Microsoft, we found a couple of innovative ways of using it. We have a number of tablets that we have repurposed to work just in the COVID units, and we're looking to expand it if we can only purchase enough tablets for this, that our physicians and our patients and their families can now communicate using a tablet over Microsoft Teams video. And then on top of that, we have translators now for nurses, physicians, patients, and the translator to get on a Teams video conference. And that's worked very well as well. And it's also HIPAA compliant for after the pandemic. I know that CMS has forgiven some HIPAA specific rules for us to use, FaceTime and other typically non-approved tools, but Microsoft Teams video is something that will be approvable going forward because of its HIPAA compliance. And then we have an Apollo 13 duct tape solution, which I thought was incredibly clever that our nurses came up with. If you might imagine, and I think many hospitals like us did this, in anticipation of the incredible potential surge of ICU patients, we thought that we would exhaust our ICU bed capacity. And so we ended up taking our single bed occupancy ICU beds and making them double occupancy. 2 beds, 2 ventilators, 2 vital signs monitors in every room. Well, this is a technological problem because for IT, there's only 1 jack for 1 ventilator and 1 bed. What do you do with the data feed from the second ventilator and the second feed from the vital signs monitor? You can't monitor the second bed or bed B from the central nurses station, right? What are you going to do? And initially, what we ended up having to do was post an assistant, a CNA, someone who could stand at the door or sit at the door of the 2-bedroom and say, I hear an alarm going off. And what an incredible waste of a person. And so we ended up using a tablet like this. So you put a tablet on the stand, you roll the tablet up to the vital signs monitor and the ventilator display, and you face the tablet there, and then you put a second tablet at the central nurses station so that the Teams video becomes effectively your monitor for bed B. So we thought that was a very cool sort of Apollo 13 moment of, oh, we have a crisis and how do you do it? And there's no, rather than tearing out the wall for hundreds of ICU rooms, you know what? We use Wi-Fi and tablets and that'll work for us. We also have Epic Secure Chat. So there's an instant messaging system inside our EHR. And then at the same time, we have a number of nurses early on in the pandemic when our ORs were completely closed. We have an entire fleet of nurses who are sitting at home going, I don't have operating rooms to support. What can I do? And at the same time, we have COVID unit nurses who are gowned and gloved saying, I can't answer my phone in my pocket because I'm gowned and gloved. And so my patients can't communicate with their families. Families are calling in and asking, can I talk to the doctor? Can I talk to the nurse? And you can't because you're scrubbed in. And we found that having these nurses at home dial into, and what you see here is an ICU rounds taking place, and the phone conference is live. And so not only is the social work on the line, the pharmacist is on the line, but these nurses are working from home. We call them nurse communicator liaisons, and they can actually listen in, understand what's happening to the patient, look at the EHR chart, and then call the family. And then furthermore, communicate throughout the day using Epic Secure Chat. This is the asynchronous tool that they can ask questions all day long. And then the nurse who's at the bedside can say, the next time I scrub out and move between patients, I can pick up all my messages and figure out how to connect and communicate with family and with these nurses. And that's been an incredibly beneficial relationship for our families to keep them involved. Because many patients, we don't allow visitors at all because of the isolation. So that's been an incredible use of tools that just work. It's not designed for that, but it's worked well. However, what I think is important is human connection. And in many ways, I think we do, this is a duh moment. Well, of course, duh, human connection is important. But, I would re-emphasize that. I would say informatics and innovation is a team sport, as you know, right? I've been in this role for 23, 24 years. And in my early going, I have lots of failures, lots of potholes that I've stepped in, lots of innovative tools that, on the drawing board look fantastic. And then when you go to implement them, why didn't that go? And it turns out, I wasn't thinking of this as a team sport. So how do you create a high performance team? And it's at its foundation, trusted relationships. And to this day, I go back and think about my trusted relationships and my regular relationships where, you know, maybe I need to do better with developing higher trust in the relationships I have in order to do better in the projects that I want to do, or to help my colleagues do better in their relationships, in their projects. So I would suggest to you, there's a couple of books I would look at. If you've read this before, read it again. If you haven't read it, you're in for a treat. This book, Team of Teams by General Stanley McChrystal, talks about the war in the Middle East and how he was leading a team of hundreds of thousands of people and the best technology in the world. And at the time, he was losing to Al-Qaeda, right? This network of fighters who were very nimble and could make changes on the dime. And you would lose if you were using the old way of thinking about things. And I'll just highlight one of the three things, three things in this book that I took away: shared consciousness, trusted personal relationships, and a centralized strategy, but distributed decision making. It's totally worth the read just for the story's compelling and it's a great fast read. But on top of that, I took a lot of lessons away for IT. And I'll just highlight the idea that shared consciousness was the idea that he set up a daily meeting with all of the military services that normally don't talk to each other, and had frontline people report out, this is what's happening, this is what I figured out, this is the result of the raid from this morning, and this is what we're finding out, who do I send this data to? And being able to, on the fly, distribute information so that you could take advantage of it hours later rather than days later, which was typically too late. And so the idea that we're setting up Command Center reflects that. The fact that we set up actually what we call the daily jig, which was something that we did in informatics, the joint informatics group. Our nurses and physicians would meet for 30 minutes each day to translate the new decisions out of Command Center each day into tools that would be actionable later that day by the whole health system. And being able to be nimble that way was. And I'm sure many of you have read this book. It's time to reread it. We're moving to virtual care. And with virtual care, instead of in-person, high fidelity, nonverbal body language and tone of voice and so forth, now we have a little thing that's 3 inches wide. And now you're trying to figure out, did that guy believe me when I said that, right? So sure, so you have video conferences. Sometimes the video conference results in, no image. Someone doesn't post their image, so you don't know what the body language looks like. And even if they do post their image, it ends up being either a small image on your smartphone or a tiny square on your video screen, with a gallery of a dozen people on screen. And is it easy to misunderstand? Absolutely, it's easy to misunderstand, right? Especially in this time of anxiety. Are we communicating very well? And so there are some of the highlights of that book. Start with heart, make it safe, master my stories. It's very easy when someone critiques you, when things are moving quickly, and it's easy to misunderstand, and tell yourself stories about that other person. Oh, that guy just has it in for me because nothing I say he likes. Well, no, you need to master your own story. All you know is the sentence he said, and you shouldn't put a story on top of that. And it's very easy to put that story there, and you need to take it back and go, all right, what would a reasonable person who said that, why would they, oh, maybe it's because they were looking out for their colleague. So anyway, I love the tools inside this book, and it's worth a reread in this time of virtual care, virtual communication, that it's easier to misunderstand. We took our sprint team. We were happy to publish our results with the EHR sprint team. We have a team of 11 people who were working clinic to clinic to reduce the burden of the EHR documentation and the inefficiencies of the EHR. And this team had to completely stop because we took many of our clinics virtual. And so they pivoted and actually trained our clinicians on video visits, right? So in the course of 10 days, 10 weekdays, 2 weeks, we were able to train 1,600 providers on how to conduct a video visit. Now, notwithstanding that the IT team had instituted video visits a couple of years ago, and we just didn't get any uptake. Clinicians are like, why would I change what I'm doing in clinic, right? In clinic, I have vital signs, I have lab results, I have all these procedures that we've honed over years. Why would I uproot that and go do video visits? And then early to mid-March, you would imagine a lot of clinicians are going, whoa, all of our clinics got shut down. Hey, wasn't there this guy last year who came by offering us video visits? How do we get in touch with that person? And suddenly we had thousands, literally thousands of providers saying, when and where can I get trained? And so we actually stood up hourly training for video visits from 8 to 5 p.m. from Monday through Friday for 2 weeks. And that's how we got 1,600 providers trained to be thoroughly proficient in video visits in that time frame. And as a result, we went from 20 video visits a day across our system to, at the end of that time, running about 4,000 video visits per day. It's a pretty incredible turnaround. So keep sprinting, right? It's great that we have a nimble team that can pivot on a dime. I want to point out that I do write a blog. So this is self-promotion at this point, ctlin.blog. And within the past month, I wrote a white paper on video visits and improving the patient experience. So once you get over the hurdle of technically, how do I get connected? Which that's great. And then now you have to deal with this tiny screen of a person and you can't put hands on, you can't do a physical examination. How do you do a good interview? And so I put down a couple of things. I love that my life in the communications literature and my life in IT, not a lot of people cross over between those two areas. And so I put a couple of tips in here from the communications literature that may be particularly helpful for remote communication, telephone or video conversation. I'll point out here on the right side, and this, by the way, this PDF of this white paper is available on the blog for download if you like. I know the words are very small, but I'll point out under reflective listening, right? So most of you probably know what reflective listening, which is saying back what you heard. And if you're like one of my residents, they're like, oh, why would I double the length of the visit to waste time to say back what I heard? I should just keep going. And these are the same residents who keep complaining, patients don't believe me, and why is it that my visits don't go very well? Well, guess what? You're not doing enough reflective listening. So reflective listening is saying back. And I would take you to the next level, that there's basic reflective listening and then there's sort of advanced reflective listening. So basic reflective listening is reflecting data. So when a patient says, so it's been 5 days, I'm getting worse, you would say, so it's been 5 days of worse symptoms, right? But then you can also reflect ideas, feelings, and values. And that's not very often done. And if you do that, that actually helps with cementing a solid relationship. And here's a couple of examples. So ideas. So a patient might say, well, I think this is gout. And I would say, so you think this might be gout? And you might say, well, isn't that a waste of time just saying back what you've heard? But this is reflecting and validating a patient's idea that this is my theory. And you notice you say it in a way that doesn't say, well, you're right. Because in this case, the first time I heard this, I had a patient who said, I have abdominal pain and I'm reading online, it could be gout. And I'm thinking in my head, that's a ridiculous idea. And rather than saying, that's a ridiculous idea, I'm saying, oh, so you think it might be gout? Well, from my medical training, I'm not quite sure I agree with that, though. Can I talk about what I'm thinking? And so that can be quite powerful to say, yes, I acknowledge your idea, and let's talk about why that idea may or may not be correct. Same thing with feelings. So you're worried about work, or same thing with values. So what's important to you is your family. And having these phrases ready to go, practicing them and using them with patients, and I would dare say with colleagues, then these conversations actually can go quite a bit better than perhaps they were before. Another framework that we've used is called PEARLS, and I won't go into it in much detail. You can read more about it, but the acronym stands for partnership statements, empathy statements, apology, respect, legitimization, and support. And these can be quite powerful. When you recognize that a conversation is not going well, these can be quite powerful tools to get it back on track. So anyway, there's more here, and I welcome you to come and read that further. And that's basically it, right? So you can contact me through LinkedIn or through Twitter or through my blog, but I'm hopeful to have a good conversation with all of you in regards to, relationship building, trust building that powers innovation. I have a couple of breakout questions I'm going to pose for you to talk about in the breakout, and I think that'll be sent to you also in the chat function when you get to the breakout sessions, would be, how are you taking care of yourself? I would be interested to hear how each of you are, because this is a stay-at-home time. It can be quite anxiety-provoking. We all consume too much social media, too much TV, and hear the bad news and take it on ourselves. How do you create trust at work? And how has that helped you innovate or be effective? And who do you need to build more trust with to be even more innovative or effective?
CT, I'm going to ask one question and then see if any other folks have some questions before we give you about 5 minutes for a closeout ukulele performance. And I love the lyrics that you came up with for the particular song. But the question I've got is around sustaining innovation. You are implementing some solutions, adopting technologies, and there's a lot of change, obviously, that's been going on. Have you looked at or found internal allies or internal folks to help you continue to sustain innovations that may not have been part of kind of the culture before COVID-19? Maybe you can speak a little bit about sustaining innovations, identifying allies, and how you can keep kind of the adoption of technologies and innovation going post-COVID.
Yeah. So thanks for the question. We're fortunate in that we did actually stand up what we call our innovation center. It's been 3 years ago now. It had been well funded, and many of its projects actually did translate into informatics tools that we ended up putting into the EHR, and I exhibited some of them today. That's elevated their status. They were already high priority, and they sort of moved up in status even beyond where they are today. And we've, in our daily huddles that we did, actually those relationships got cemented quite well. So we were very fortunate that we started from a good place and had good conversations daily to figure out how we best work together so that we can accelerate that further. On top of that, there are a number of operational folks who weren't as well tied in, but because of the forced command center daily huddles, we got to know them a lot better too. So our leadership actually gelled quite well around a number of these projects, not just innovation, but operationally. I never talked with our finance folks regularly before. I never talked with the COO regularly before. And now these are conversations that are relationships that have taken to the next level. So we think that, we have an internal phrase, I'm sure everyone does, the never go back set of things. What are the things that we'll never go back on? And we think that we won't go back to quarterly meetings. We'll talk about brief, short huddles where we can touch base with each other on a faster cadence, and we can sustain that. Well, it won't be a half hour every day. It'll be a half hour once a week. It'll be 15 minutes once a week. So things that we can say, anything today? Nope, good, off, next time. And everyone feels like that's more efficient. So these are the types of things we're looking at. And I'm sure lots of folks are.
Excellent. And
Linda, you're on mute if you're talking.
Go ahead, Melinda, if you have a question.
Am I on mute?
There you are.
Now there you go.
Is that better?
Yes.
Yes.
Okay, great. That's fantastic. We did the exact same thing. We set 9 o'clock. All leadership called in at 9 o'clock. If there was no big deal, we were off in 5 minutes. But if anyone had a communication link, for one thing, everybody had an opportunity. If something changed from yesterday that we weren't expecting, or, we got slammed with the number of patients or whatever, we all had that opportunity to bring up either a solution or a problem at 9 o'clock in the morning. And everybody had that opportunity. And if we were done in 5 minutes, great. Otherwise, we solved the problem and then went on with the rest of the day. And I really think that daily huddle is a wonderful thing for leadership.
We've actually done that internally at Chime. For about 3 months, we had daily huddles for the entire leadership team, working through issues, and it was very effective.
Yeah.
So we've got just about 5 minutes left. Just a couple of closing conversation or topic items here. I wanted to thank Greenway Health, Kali, for supporting the series. We've got 3 more coming up: Shafiq Rob at Rush on Monday, Dan Nygren from Boston Children's on Friday, and then another one the following Monday. The one next Friday, Dan's going to be talking about contact tracing and the technology that they developed at Boston Children's and implemented in the Boston region. We're also going to send out a survey, so really appreciate your input. This is a new program for us. And for those that are watching the recorded version, if you've got input and some feedback for us, please provide that. We're all ears, and we want to be able to provide programs and products that meet your needs. So with that, CT, take it away with the ukulele performance.
Woohoo!
Okay, Feel free to sing along on mute. So this is called Ortho Virtual Care. I wrote this actually before the pandemic, but it seems appropriate today. I see surgeons in green. There's a video screen. There's no need for patients to travel to be seen. And I think to myself, what a wonderful world. I see history reviewed, consent form signed, the procedure recorded, the charges are mine, and I think to myself, what a wonderful world. The colors of the rainbow, so pretty on the screen, also indicate healing on the joints of patients seen. I see friends waving hands, saying, how do you do? They're really saying, epic, I love you. I see patients on screen. We wave hello. Their pain is well controlled. I watch them get up and go, and I think to myself, what a wonderful world. Yes, I think to myself, what a wonderful world.
Woohoo!
All right.
Yeah,
Excellent, CT.
absolutely. Can't beat that.
Wonderful. Well, thank you very much. Thank you everyone for participating today, and please do register for the remainder of the Innovation Beyond the Edges, and have a wonderful weekend. Thank you.
Yeah.
Bye-bye.
Thank you. Bye-bye.